I am Mohammed Shaheer Akhtar, postgraduate resident, Lead Reading Hospital, Peshawar. So the topic of my presentation today would be transoral odontoidectomy for congenital basilar invagination, our experience in limited resources setup. So basilar invagination in simple words is the abnormal prolapse of the odontoid process into the already crowded foramen magnum. It is usually accompanied by atlantoaxial dislocation, and it usually doesn't occur alone. There are other associated pathologies like atlas assimilation, syringomyelia, anomalous course of vertebral artery, and congenital fusion of the upper cervical vertebra. These all are relevant to the surgical intervention because they make the anatomy of the region very complex. So traditionally, basilar invagination was divided into two groups by its reducibility. If the alignment was achieved via extension or preoperative traction, then a posterior fusion only would be performed. But if full alignment couldn't be achieved by these methods, then anterior decompression via transoral odontoidectomy or transnasal, transclival, or any other approach followed by a posterior fusion for the irreducible type. So since the last 2 decades, the treatment of this has changed dramatically since the advent of posterior distraction by Goel, and recently Chandra's DCER, distraction, compression, and extensive reduction. Now almost all cases are advocated to be treated from the posterior only approaches. So are there still indications for transoral odontoidectomy? We performed transoral odontoidectomies for severe compression due to atlantoaxial dislocation and basilar invagination that cannot be managed with a posterior only procedure that we think is unsafe in our hands to be managed with a posterior only procedure. It is also used as a salvage procedure after a posterior only approach if it was unable to completely reduce the pathology, and for other inflammatory or infectious causes compressing the CVJ. So what do we mean by limited resources? We work in a government hospital. A significant portion of our patients cannot afford modern implants or gadgetry. We perform these procedures without the neuromonitoring or navigation, and we have limited HDU and ICU facilities. The study was performed in Neurosurgery Unit, Lead Reading Hospital, Peshawar from 2017 to 2020. 21 patients with AAD and BI who fulfilled the criteria were included in this study. Infectious or inflammatory pathology, history of trauma, and tumors were excluded from this study. So diagnosis is made in a standard fashion with the McGregor line, Chamberlain line, McRae line, Veckenheim line, all those standard textbook methods. So surgical procedures, the patient lies supine on table in a slight Trendelenburg position. The neck is slightly extended, and a fiber optic orotracheal tube is passed. Tracheostomy in our setup is only reserved for very severe preoperative bulbar respiratory disturbance, especially because there are limited postoperative ICU facilities available. A low-profile self-retaining transoral retractor system is used. Uvula is retracted away. C1 tubercle is palpated and confirmed on image. The midline incision is made from the clivus to C2-3 intervertebral disc. Anterior arch with odontoid is resected, and NG tube is left in place. And the patient is then shifted into a prone position, and posterior OCF or C1, C2 is formed depending on the pathology. If there is atlas assimilation or whatever could be possible in that set. So both are preferably done in the same setting. However, we have performed 2 patients of these 21 in 2 different settings due to a variety of reasons. So a total of 21 patients with a mean age of 21, 8 who are female, 13 male. The most common presenting complaints were gait instability and limb weakness. The associated abnormalities, the most common was atlas assimilation that was found in 66% of the patients. C2, C3 fusion, clipal field, was found in 3 patients, 14%, and anomalous vertebral artery also in 3 patients. We measured the numeric scores pre-op and post-op, and modified Japanese Orthopedic Association score. So pre-op and the score that we have compared it with is with the final follow-up. So the Neurosurgery score improved from 2.29 to 0.95 on the final follow-up, and modified Japanese Orthopedic Association scores to 11.6 to 14.9. These are some of the cases. This is a 12-year-old kid. The consent has been taken from the patients regarding their identity. This one with the almost vertically oriented C1, C2 joints that we thought was unsafe from posterior, and the C2, 3 vertebrae were fused, and the C3, 4, 5 were fused. And this one with LS assimilation. So the complications in our setup were, in these 21 cases, we had 2 vertebral artery injuries. Both patients were diagnosed post-operatively with increased bleeding from their wound site in the wards. Tracheostomy was performed in 3 patients. There was tongue swelling in 1 patient post-operative. The wound infection in 2 patients, chest infections in 2 patients. Among the vertebral artery injuries, 1 was managed conservatively post-operative. After management, the angiogram showed no anomaly, and the patient had no neurological sequelae. However, 1 patient developed a pseudoaneurysm that was surgically treated.
You have 1 minute.
Okay. So a mean follow-up of 6 months was completed. Symptoms significantly improved in 90% of our patients. The conclusion is, in the setting of a low resource setup, transoral odontoid resections can be safely performed for select patients that are properly selected according to criteria. Thank you.